And, you know, it's 11:36 and we already have about 35 people on. So I think we're going to go ahead and get started. We have a very good program today, and my thanks to Laura Boyd and to Randy Tate for putting this together for us and pointing this need out to us. Our speaker today is Allie Friesen, who is with INTEGRIS Health Center and Health System. Allie is a graduate of Texas Christian University, and she has graduate studies at the University of Texas Southwestern Medical Center. She has a master's in clinical rehabilitation counseling, and she's nationally board certified counselor, a licensed professional counselor, certified rehab counselor, and is a member of the American College of Healthcare Executives. Most importantly, I'm going to let Allie introduce herself a little bit. Laura had planned to introduce her, but this is what I know. I know that this past April, 5 months ago, Allie was reading numbers and paying attention to what was happening in the emergency departments of hospitals in central Oklahoma. And what she observed is a 117% increase in the number of ED visits for the adolescent population related to suicidal ideation, 117% increase. And rather than just, I'm sure it upset her and she was concerned, as it does all of us, but rather than just think about it and tell a few people about it, this young woman got into action and brought together partners with North Care, and Laura Boyd, I think, is involved with INTEGRIS, and I'm sure she talked with Dr. Boyd. But we are so honored today to have Allie here and have her tell us about the fact is that this group of people not only identified the concern, but they now have a program that is helping to solve and serve these young children and families that are dealing with this crisis. Allie, we're going to turn it over to you, and I'm going to remind everyone, if you have questions, you can send them to the chat, and we'll make sure that she answers them. At the end, she's got a slideshow, and she will provide ways that you can contact her later on. And just in case anybody wonders, I guarantee you that there's going to be an opportunity that you can all help if you'd like to be a part of the program. Allie, thank you so much, and the program is yours.
Of course. Thank you so much, Karen. And thank you all for having me today. I am, of course, wishing that we could all be in person. We know that engagement is just different in this virtual environment, but nevertheless, I am pleased to be here and honored to have the audience that I do and have the chance to discuss some of what we've been working on. As Karen mentioned a little bit about myself, I am a clinician by training. I was offered this position to be the director of the behavioral health clinical program for INTEGRIS Health. So that means I am over all behavioral health clinical work across the INTEGRIS Health System. And as we all know, behavioral health, a lot of the work takes place outside of these walls, outside of the hospital. And that's really been part of my strategy, is to invest in those community partnerships and align our evidence-based practice in the community. So we're preventing individuals from reaching the point of crisis where they need to show up at our emergency departments. So this is a very, very challenging role, but I love it. Very much miss the patients, but the way I like to look at it, I have the potential of impacting tens of thousands of people, hopefully, if I do my job well, versus maybe 8 patients a day. So honored to be in this position and work with my wonderful colleagues and our mental health community. So a little bit of background about how we got to this point. As Karen was mentioning, we did see an alarming spike in our emergency department, and we will dive into some of those statistics. And we decided to hold a symposium on June 21st. I do not recommend planning a symposium in 5 weeks' time. It proves to be fairly stressful, turns out. So I got to test some of my own self-care and mental health strategies. But it was, considering the 5-week time frame and COVID and summer vacations, we did have a pretty impressive turnout, and that's something that we envision that will continue to take place twice annually. So we're very excited to see how that evolves. Steve, if you want to go ahead and pop up the slides, this is a lot of Allie right here, and we can dive on in. Wonderful. All right. So we are here today to discuss the adolescent mental health crisis, and particularly diving into the COVID-19 impact. Next slides, please, Steve. And I do not want to fail to mention at INTEGRIS Health, our mission is, of course, to partner with people to live healthier lives. And our vision is to be the most trusted partner for health. All right, so discussion points. We're going to dive in today to current statistics and trends that we've been observing both nationally and locally. This is something that has been kind of splattered across all of media, and I know those people on this call are paying particular attention to those headlines related to mental health, especially of our kiddos. So we're going to dive into a little bit of what we're seeing and then launch into actual what's happening, what is the impact from COVID-19, why is this impacting our kids the way that it is, and then the information we all really want is next steps. What do we do? How do we help? How can I leverage resources in my area of expertise? How do I get these kids the help that they need? All right, so let's keep going, Steve, if you don't mind. All right, I'm going to move this little box. Okay, so if we look at some national statistics, we can see what's important to mention is that this is not something that has just started rearing its head after the pandemic initiated. So this is from 2016 through 2020, you can see that the trend was already increasing. And this is deaths per 100,000 adolescents, ages 15 to 19. And pre-COVID was the second leading cause of death for this age range. Nearly 20% in 2019 seriously considered suicide, and about half of them actually attempted suicide. And we start seeing this increase in ED visits right on the cusp of COVID. In 2020, our mental health related ED visits for the ages of 12 to 17 increased 31% compared to 2019. And it's important when we talk about these emergency department statistics to remember that the kiddos that show up to our emergency departments, this is the very tip of the iceberg. These are the most extreme circumstances, the most severe crises that are leading these individuals to our emergency departments. So that means that at some point, or probably multiple points, we've missed opportunities, whether it's schools, whether it's extracurriculars, whether it's church, whether it's ambulatory medicine settings. We've missed options to intervene and signs for these kids that are having a hard time, and they had no other choice but to show up at the emergency room. So important to remember, these trends were already on the rise prior to COVID, and they have since continued to explode. Next slide, Steve. All right, this is really interesting, and this is very busy at first glance, so stick with me for a second. So this is divided up by sex. So the top left figure is reflective of girls, and the bottom right is boys. So this is reflective of numbers of weekly emergency department visits for suspected suicide attempts. So this is not presentation strictly for ideation. These are actual attempt-related visits, again, for the 12 to 17 year age range. So if you see the solid line that is incomplete across the figure, that's because that's 2021. And the large dash line is 2020. So interestingly, and what I really like to pay attention to on this slide is the girls, the trends that we're seeing and the alarming discrepancy between 2021 and 2020 for our girls around the same time of year. So you can see that highest peak of around 1,000 weekly emergency department visits for suspected suicide attempts in comparison to the approximate 400 weekly visits at a similar time frame in 2020. And it's interesting to compare the trends in the girls and the boys that we've actually been seeing a decrease in 2021 in terms of their visits for suspected suicide attempts. So that makes you, my clinician brain kind of takes a step back and starts thinking about what's the difference here? What's contributing to kind of the internalization of these emotions? Why are we seeing a spike with girls and we're seeing a decrease with boys? So it's really interesting from a clinical standpoint, and I'd love to dive into some discussion with you all at the end of the presentation and get some feedback on your thoughts around this. And this is an interesting phenomenon from a research standpoint, because this is unlike anything that I've ever seen in my clinical experience. It's the comfort in clinical work knowing you can read the literature and at least find something similar. And there has been some parallel research done with natural disasters and with kids and how they cope with natural disasters and traumatic situations, but truly there's nothing like this that we have to compare it to. So we're truly doing the best we can as we go. And that's all the more reason why we need to stay in tune and have an accurate pulse on what's happening with our kids and all lock arms and work together in the same direction. So interesting data to keep in mind. Let's keep it going, Steve. All right, so here's some local data from the INTEGRIS health system. So this is very interesting for me to look at, and actually is wonderful to see. So that red dotted line is our linear trends line. And you can imagine what this looked like just through April. It was a straight up incline in terms of our trend line when we were at our highest peak. So I am pleased to say we have seen a decline in our pediatric emergency department visits related to suicidal ideation. So there's a lot of text on the bottom. All that is our different INTEGRIS health locations. And what's really interesting is if you look at March and the spikes we started seeing, BMC is our Baptist location. And then the second largest spike that we saw in March was our Edmond emergency department. And that's really where I started my work with the school systems, was in the Edmond Public School District, because we've never seen this kind of spike. It was terribly alarming. Baptist and Southwest Medical Center, these things ebb and flow for all of our age ranges and for all of our populations. So it's not unusual to see a spike specifically in our young adult and adult populations, but to see the pediatric visits spike like this in that area was really unusual. So that in particular was what led me to start conversations with our Edmond Mental Health Committee in Edmond Public Schools and ask, what are you seeing? What are we doing? What tools do we have in place for our kids? So as Karen mentioned, we really started these conversations in March and April saying, hey, we have to do something. This is not okay. It's not okay for any of our kids to show up with wanting to harm themselves. But these are astronomical numbers that we were seeing. So myself and our chief medical executive, Dr. Julie Watson, and some of my colleagues, we started discussing ideas and what we could do. And the idea was thrown out. Let's try to get key stakeholders in a room, all in the same place. Anybody that can potentially impact the life of these kids, whether it's a coach, whether it's a pastor, law enforcement, pediatricians, emergency department physicians and nurses, mental health providers, from psychiatrists to community mental health providers. How do we get everybody together? And that's really how we started coming up with this idea of this symposium. And the concept behind the symposium was to create alignment, right? So to establish that basis for collaboration, because we're all trying to accomplish the same thing. And there's so much separation and so many silos across our state in terms of mental health treatment. And really, we've taken it on to try to break down those silos and really try to streamline the efforts. So the symposium was an all-day event where we focused on the gaps in current practice and what are our obstacles and what is evidence-based practice, what should we be doing. So we then utilize the obstacles, or what's preventing us from operating an evidence-based practice, and we prioritized and voted on those obstacles in order to drive our work of the task forces that I'll be talking about a little bit more as we move forward. So it really was a wonderful event of getting people in the same room. And like I said, we'll be planning to continue that work twice a year. So let's keep going before we get back into the task forces. Thank you, Steve. All right, so let's transition from statistics and trends to what's causing these numbers, what's causing these problems across our country and across our state. So anxiety, stress, and fear, we are not the only ones that are experiencing these emotions on a daily basis. No person really across the world has gone without any of these three emotions over the last 20 months. So we know that kids, we say when they're really little that they're sponges and they soak up everything that they hear and everything that they see. That doesn't change when they're 14. And I know I'm preaching to the choir here, but they react to that observed stress from parents, caregivers, peers, media that they're exposed to. They hear it and see it all and they internalize it. We're having anxiety, stress, and fear from parents not being able to provide appropriate care due to their own mental health concerns, due to their neurological concerns due to passing away from COVID and kids being left without their primary caregivers. Economic strain has been a huge one that we've seen, people losing their jobs, losing that stability. And we'll talk a little bit more about that in a few seconds. And we know that having this lack of supportive adult relationships it is harmful to our children's ability to manage this toxic stress. So we truly need those supportive adult relationships to act as a buffer. And we know that we've seen kids removed from their social networks outside of their primary household and losing a lot of those adult constant safe relationships. Interestingly, the impact of COVID-19 has been observed to be more pronounced in ages 11 to 17. And there's not a lot of clear and consistent literature behind why that is, but I think we can utilize some of our common sense and even basic clinical understanding that neurologically we're in such a delicate stage of development at that point that we're susceptible to so many external influences and so many social influences or lack of social influences at this point. So that's kind of what my gut's leading me to at this point. So another interesting statistic here for you. So Mental Health America, which polled about an N of almost 400,000 individuals, observed that their online anxiety screenings were 535% higher in August of 2020 than in January of 2020. And similar and even more alarming, the online depression screenings were 709% higher over that same time frame. I mean, there are no words when you see figures like that. So it is very clear that this is not an issue that is going to go away. This anxiety, stress, and fear will continue to evolve. And I am of the opinion that it's going to get worse before it gets better, not only due to the variants and the additional surges that we're seeing, but with the continued uncertainty and lack of structure and consistency with our kids. And we know that neurologically they crave that and need that in order to be successful. All right, Steve. Okay, so let's talk a little bit about the social determinants of health. I know a lot of you are directly involved with work that aligns with improving these social determinants of health for our kids. So we know that poverty, food insecurity, housing instability, all of these things way prior to COVID, we know has a huge impact on the overall wellness and health of our kiddos. And unemployment among parents, when we observed the increase to 10.8%, the risk of children's mental health problems increased by 94%. So that can be confusing at first glance. That does not mean that they are 94% are developing mental health problems, but that just shows us the relationship between parents' unemployment and economic instability and the increase of the risk of children's mental health problems. So we're increasing that risk almost 100% if we have a parent that is facing unemployment or that economic instability. Social distancing, quarantine, and isolation. Man, we could have a whole presentation just on this. And I know this is largely in discussion in terms of the impact that this is going to have on our kids long-term. And sadly, only time is going to tell what the impact has or what the impact is on our kids. This statistic stood out to me that 30% of children who have been quarantined meet criteria for PTSD. So let's think about that as we transition to the school year, as we return to in-person learning. 30% of these kids are showing up to in-person learning with these clinical symptoms. The clinical symptoms have not dissipated. So we know it's very unlikely that our kids are going to seek out an adult, seek out a teacher, and say something's not right. I don't feel like myself. I'm having all these thoughts. I'm afraid all the time. We know that's terribly unlikely. So how are we identifying these children and how are we connecting them with the services that they need and helping them understand why they're experiencing all of these things? If I'm 13 years old and I'm having flashbacks and I'm anxious all the time, I don't even know really what anxiety is. I know maybe I feel like I have butterflies all the time and I can't kind of figure it out. So we cannot count on our kids to initiate these conversations. So across our community, we have to be in alignment in terms of the language we're speaking and the tools and the screening that we're putting out for our kids, so that we can cast this wide net and catch those kids that need to be connected to services before we see them showing up at our emergency department because they can't handle living with these symptoms anymore. So that is so powerful in terms of understanding what it looks like in real time as we transition into this next season for our kids. So as you can tell, I could talk about that for a while, but we got to keep going. So child abuse and intimate partner violence, again, not a new issue, but COVID has exacerbated these problems that we're seeing as we've been in quarantine, as we've been isolated. Kids are in these unstable environments and they do not have their regular sources that they can discuss. They don't have an aunt or uncle they can call. They can't go to a friend's house and get away from the chaos. They can't be identified by a school counselor that maybe their behavior has changed a little bit, or maybe there's a bruise that wasn't there yesterday. These safety nets have not been in place. So we're likely to continue to see significant increases in children that are exposed to this maltreatment and domestic abuse because the impact of COVID-19, economic strain, social isolation on these households that have been forced to be together that maybe are not in the most healthy state of relationships are going to completely overtake the dynamic of the household and impact our kids. So again, same song, different verse, that we have to be in line across the community of what signs to look for, what tools to use when we screen them for any kind of concerns, and what are the resources that are trusted, that are providing evidence-based care. Steve, next slide, please. All right, education. So again, we could have a whole presentation just around education and what we've seen over the last 20 months and now transitioning back to in-person learning. So what I really want to focus on, however, is the inverse relationship between suicide and academic success. So what does that mean? That means that children with academic challenges are 3.1 to 7.4 times more likely to attempt suicide. Whereas conversely, having academic success is actually a protective factor against suicide. So I struggle, again, I'm biased, I'm a mental health professional. I struggle when we meet friction from our school systems and from our educators to incorporate mental health and to understand the relationship between social and emotional learning and academic success. To me, that is on us as a health system, that's on us as mental health advocates and providers to communicate that the important message of the connection between mental health and academic success. So I frequently have told educators and administrators in the school system that it is not their job to care for their mental health. It is their job to promote academic success and development. So let us, as the mental health community, help support you in understanding what frameworks need to be in place in order to reach success, both in terms of the kids' mental health and academic success. Because if we take care of the mental health, it's more likely we're going to see academic success, of course, contingent on learning disabilities and other factors. But it's so important, and I don't know that these conversations are taking place consistently across school districts. And our more fortunate, more well-funded school districts have had the chance to recruit mental health teams and more robust multi-tiered systems of support, which we'll talk about a little bit more. But for my community advocates on here, I encourage you to partner with your schools to be a champion for these systems of support that our kids need to be successful, both emotionally, socially, and academically. It is of paramount importance as we try to navigate through this process. Social competence. So this is a big conversation in my household. My husband is not a clinician. He's in oil and gas, could not be more opposite of worlds. But we have a 9-month-old baby girl, and she is our first, and she was born into a COVID world. So she goes to daycare down the street at our INTEGRIS Health Children's Place, and they are fantastic. I trust them with all of my being, but they wear masks. And from a safety perspective, I respect that and appreciate that. But then you think about it from a language development standpoint, from a social skill development standpoint, what kind of an impact is this having on my sweet Olivia Grace when she's at school all day and all she sees is adults in masks? So of course, I try to look at it, through a positive light, that she has parents that are aware of this and try to encourage as much face time and expression and emotional learning as we can. But we know that's likely not the structure in most households where kids are exposed to masking mandates. And how is this impacting their intellectual, social development? And how do we support the appropriate structure and compensatory strategies for these kids to help them continue on the positive trajectory of learning and skill development? So it is, again, only time's going to tell kind of what the impact is, but it's on us to support our families and to support our communities however we can in maintaining this social competence. And I mentioned the safety network before. I am hopeful that as our kids return to in-person learning, we will start seeing a decrease in mental health concerns due to the reestablishment of the safety network, having our school counselors, having other trusted adults present that they feel that they can interact with and confide in. So I'm hopeful that I am right in my hypothesis there. Steve, next slide. All right, so what now? Probably what you guys are really interested in. So most of you are probably terribly familiar, maybe even involved with some of these initiatives. So I do not by any stretch claim to be an expert across all of this work that is being done in our state. And I do have to say kudos to our federal and local governments for realizing the importance and the impact on mental health across our communities. There is a robust amount of funding that has already been allotted and is planned to be allotted to continue to build out our mental health services. So I'm very grateful for that. And I think we can all agree that it's been a very maybe dull silver lining to COVID-19 is the opportunity we've had to look at mental health, and individuals cannot ignore it anymore because it's impacting every single one of us. So community hope centers, we have, I think the final number I saw was about 27 community centers that have been developed through the Oklahoma Department of Human Services in OU Tulsa. This is for those children that have been exposed to adverse childhood experiences as a result of COVID-19. And from what I know about these programs, they seem to be terribly comprehensive, providing trauma-informed services, enrichment, access to meals, additional resources like financing for families, basically helping get kids what they need in order to overcome these adverse experiences that they've been exposed to. So I'm anxious to hear if any of you have been involved in this work. Engage community and family, similar concept. This is more of an outreach plan and provides education on the potential impact of mental health and education and overall well-being as a result of COVID-19. And our Department of Mental Health and Substance Abuse Services, they have comprehensive evidence-based suicide and self-harm interventions. And I've had the privilege of getting to know some of the leaders at our Department of Mental Health and all of the amazing work they're doing. We have the 988 number that is planned to be launched in November of 2022. We have the privilege on working with our community mental health centers and trying to build up that infrastructure under that 988 number to really improve the likelihood of success and utilization of that portal. So I am really anxious to see the amazing things that come from that. But they're doing incredible work. So I encourage you, if you haven't spent time on their website recently, to spend some time looking at the comprehensive crisis response, everything from mobile crisis teams that I know Randy Tate and his team are heavily involved in, to improving universal screening, transportation changes. There's a lot in legislation currently that is slated to greatly impact mental health and the way that mental health crises are treated across the community. So a lot of positive change on the horizon, which I'm very excited about. So a lot of acronyms here with our schools. You heard me mention multi-tiered systems of support. So again, I'm not an educator. I'm not a school counselor. I do not claim to be an expert in this area, but in my last probably 8 months of learning more about the school system, about social emotional learning, about what we have in place, what is best practice, The literature that is available points to these multi-tiered systems of support being truly one of the best options. So I encourage you, in all your free time, to do some quick searches on multi-tiered systems of support. I will provide some links for you all. A Healthy Minds Policy Initiative out of Tulsa has a great webinar over multi-tiered systems of support. The public school systems in Tulsa have been working to integrate this framework, and at a very high level, it is a framework to provide more comprehensive preventative services for kids. So historically, and again, this is just through my lens, historically, we've had community partners and well-intending organizations try to offer preventative programs to our school systems. And although well-intentioned, the school systems simply do not have the bandwidth or manpower to maintain those programs, nevertheless track the efficacy of the programs. So there has not been a lot of consistent available funding in order for us to implement these programs over a significant period of time and actually monitor the data and how is this impacting our kids? How do we need to iterate on this process? Where do we need to focus a little more? So multi-tiered systems of support help prevent that problem. It is an actual framework that is embedded into your school system and has 3 different tiers of identification for your kiddos that might be having a hard time either academically or socially or emotionally, and escalates them through the tiers all the way to individualized intervention if they require it. So I encourage you to do a little more digging, and I certainly can provide you with some more resources on the multi-tiered systems of support. So the Oklahoma State Department of Education is aware and very heavily involved in all of the positive evidence behind the multi-tiered systems of support. And I mentioned 3 of the current initiatives that are surrounded locally for the multi-tiered systems of support. All right, next slide, Steve. Okay, additional efforts. So I mentioned the lack of data collection and tracking the impact of these interventions. So schools should prioritize Oklahoma Prevention Needs Assessment. That this continues to help utilize data and guiding where our needs are in our communities. So again, just in the interactions and exposure and research that I've had the privilege to participate in over the last 8 months or so, we really have great programs and great educators and counselors in our schools that want to be able to provide these tools, but lack of consistent funding or lack of buy-in and support from senior administration in our education system they've been the brick walls they continue to run into. And that's where we run into the burnout educators, the burnout school counselors that we know are there for the right reasons. But when you run into the same brick wall 12 times, you start kind of running out of energy to run in that direction again. So we need to continue to provide these standardized tools and instruments and training for our educators, for our counselors. So of course, our Mental Health Association of Oklahoma and the Children's Behavioral Health Network, I'm sure you're all very familiar. They do work with connection of families with children who have mental health or substance use challenges. Universal screening with evidence-based screening tools in healthcare. This is one of my top priorities. I do have the luxury of being in a massive health system, and it sounds like something that should be some low-hanging fruit. Yeah, we just get this same, standardized tools across all of our clinics. But you have to think about your clinics. You have to think about the emergency department. If we're admitted on the acute medical floor, how do those tools change in their validity based on setting? How often can we administer certain tools? So really universal screening is going to be top of mind, not only for the INTEGRIS health system, but also for these task forces as we look at the community. And you heard me mention before, how are we catching these kids? That kid with PTSD from being quarantined, when he shows up to school, how are we catching him? Are we administering an evidence-based screening tool to every kid so that nobody's feeling targeted, nobody's feeling stigmatized? We know that this is just something that we do, that we check in to see how we're doing emotionally. Mobile crisis response teams. This is part, again, of that comprehensive crisis response from the Department of Mental Health and Substance Abuse Services. I can't give Randy Tate and his team enough credit for the amazing work and quick work that they pulled together to respond to our community members that are in crisis. So we have excellent work happening with law enforcement integration, with clinical professionals, either virtually or in person. And I know that that's a strategy for the Metro and beyond, to continue embedding clinical professionals with law enforcement. And that has been proven to be a very, very effective strategy and intervention in decreasing the likelihood that they need emergency department services. And that's going to lead to improvement with our bed availability that we're seeing in our psychiatric inpatient facilities. So let's circle back to the task forces. So I did explain the symposium already in quite a bit of detail. So I mentioned that there was a voting process that took place in terms of our obstacles or prioritization of the work. So as you can imagine, with about 100 people that are very passionate about mental health, ranging from clinical professionals to community advocates, there were a lot of opinions. And there were a lot of concerns related to obstacles and similar brick walls that they felt like they've run into. And that's what we needed to start out this process. It is what's interfering and what's preventing us from doing the work that we should be doing, and why are we not reaching these kids effectively and consistently. So these are the 3 task forces that were formed. I will be transparent with you in that we've not had a great turnout of assignments in our funding task force. And frankly, it may be better for us functionally to transition the funding task force. So I think we're looking at collapsing funding into probably the evidence-based practice task force. So for that purpose, we'll say that we're going to have 2 task forces now, evidence-based practice and standardized communication pathways. So evidence-based practice is a very broad umbrella. That means, what are the best tools that we have available? What are the best interventions? Who are the best clinicians? Are we doing it consistently and in the way that we should be doing it? So this is far beyond crisis response. This is integration of law enforcement. This is in our ambulatory outpatient settings. This is in the emergency department. What questions are they asking? How are they following up with your care? How are they communicating with your family? So this work is huge, and I have empowered our task force leaders who are doing this on a volunteer basis to take these topics and to vote as a task force and to determine where they want to dive in first. In our standardized communication pathways, one of our primary areas of focus is going to be on a universal bed board. So our Department of Mental Health historically has a bed board for those facilities that are contracted with the state. However, we know there are many facilities that operate outside of that functionality. And frankly, and Keith Hayes from the Department of Mental Health was very transparent in saying the technology was developed probably in 1994. And we joked that maybe there were little Pac-Men that were acting as the patients in the bed board imagery. So needless to say, it needs a revamp. And we know that we've heard time and time again that there are not any beds. We have kids sitting in our emergency department literally for days, not having anywhere to go, and they can't start treatment. It's just exacerbating their symptoms. It exacerbates the family's frustration. So when we talk about communication pathways, that seems to be the highest priority and the biggest bang for our buck in terms of effort. So we're going to pull all the key stakeholders to the table. We have many of them there already that are needed to develop this technology and communication between facilities. And standardized communication pathways goes all the way to how are our schools communicating with a kid's psychiatrist? How's the psychiatrist communicating with the family member? How does the school let the family know that there's an observed problem with their kid? So this is very complex due, of course, to HIPAA compliance and wanting to maintain patient privacy. However, through this time we spent at the symposium, it is very clear the pieces are not talking to one another. So we've got to find a way from clinician to family member clinician, school system, pediatrician. We have to establish a more comprehensive network and strategy to communicate with one another in order to promote the success and well-being of our kids. All right.
Allie, let me interrupt. This is incredibly helpful. We are getting some questions.
Okay.
So
I'm almost done.
Okay, we want to allow 5 or 10 minutes at the end, but this is fascinating.
Perfect.
Please keep going. And you're on this this new slide on, we have the pieces now.
Yes, exactly. So I'm almost done. And I just wanted, this was a really powerful imagery. I'm a visual person. I got to see what I'm working with. You can probably see the aggressive amount of Post-its on this large board behind me. I've got to piece things out and see it. So this is helpful for me in knowing where we're trying to go. So I see us right now somewhere between the knowledge and the insight box. I feel like we started to connect the stakeholders. I think we started to connect the pieces of the problem, the obstacles that are in our way, but we have to continue to illuminate that pathway and get to the point where we have that connected wisdom and we can transition to that point of impact. So hopefully this is as interesting and helpful to you as it is to me. And if you ever need a lunch break kind of laugh, the Gaping Void website is very entertaining in terms of visuals to put in your presentations. So Steve, if you'll go to the next slide, I just want to highlight this real quick. So here's the option for you guys to sign up for one of the task forces. This will still give you options for 3 task forces, which is the funding, standardized communication pathways, and evidence-based practice. If you are passionate about funding, if you feel like you have a lot of valuable insight and information and connections that you can bring to that table, please sign up for it. As I said, we're going to integrate it into the evidence-based practice group. So by no means does that mean we are ignoring funding. That is a chronic problem in the mental health world. So if you guys are not familiar with QR codes, all you have to do is open the camera on your cell phone and it will focus in on this QR code and it will automatically load the form that you need to fill out a few questions and sign up for the task force. And then I have access to that, only me, so that I will get an Excel sheet that will populate and tell me who's signed up. And you'll have your email on there, and then I will email you and get you connected with our task force leaders. If you are watching this on your phone or pull this back up on your phone, you can click this little hyperlink that will take you directly to the same survey. And then you have my cell phone and my email right there. If you have work that you're doing that you feel ties in nicely to what we're trying to accomplish, if you have questions, if you have concerns, I am here all the time. My 9-month-old still keeps me up at strange hours of the night, so I'm likely to respond to text or phone calls. And now we can take all the questions that you have.
All right, I've got a couple of questions that people have sent me, but I'm going to ask Lee Rowland. You said you have some questions. Are you ready to ask those?
Yeah, hi, and thank you. Excellent presentation and information. I'm always concerned about the least, getting the least. And when I say the least, I mean those who are most at risk and marginalized. And I'm just curious what kind of work you've done with Oklahoma City Public Schools and beyond, because I'm an adjunct professor at SMU, and I work with future principals and superintendents, and some of the things that I feel like is pretty common knowledge that the most at risk are getting the least. Some of that's new to them. They think equality is everybody getting the same thing, and not everyone needs the same thing. So to ask them a question one more time, OKCPS and beyond, as far as especially the population, the schools that are serving these communities, how involved have you been with those school systems?
Yeah, great question. And thank you for all the work that you're doing and for advocating for our at-risk populations. That is hugely needed work. So full transparency, my work started with Edmond, again, because I was going where the data was, right? I did have the privilege of working with some of our Oklahoma City Public School social workers that attended our symposium. So very much they were invited to be at the table and will continue to be represented at the table. And that is part of the work that's going to come from the evidence-based practice task force, is that school setting and what are we doing across school systems from Mustang to Yukon to Midwest City to Oklahoma City to Edmond, all of our school systems. what are we doing and how do we know that it's successful? Frankly, the feedback I got from our participants that were social workers from OKCPS were fairly pleased with the resources that they had in place at that time. Again, I think it's a similar situation of temporary grant funding to promote their efforts at that time. But part of my goal is to align that communication between our school systems and between our legislators and between the health systems, that we're all moving in the same direction and all the parts are talking to each other. And we know that pre-COVID, our at-risk population, they're at risk for a reason. We know, just like we talked about in that social determinants of health slide, that those are the kids that are facing the threat of poverty, food instability, housing instability. So they need to be a primary area of our focus. So my answer is I have not dug in specifically in person to that, but that is very much on the agenda of our evidence-based practice task force. Does that answer your question, Lee?
Yes, thank you.
Dr. Hall, do you have a question? Here she comes. There she is.
I'm sorry, I think my audio is going to be messed up, but have you connected with any of the counselors in any of the school districts that oversee students with individualized educational programs? They're already at risk, and I didn't know if they might be a resource for you or an additional link.
Yes, absolutely. Great question. So I have had the privilege of working with some of our school counselors. Again, that work started with Edmond, but I did have the privilege at the symposium of meeting some additional school districts and some school counselors that were in attendance. So the challenge with the school counselors is that there's so many of them. So coordinating the work is difficult. But we have talked about the 504 plans, about the accommodations. How do we ensure that we're not only looking at the academic success and the behavioral modifications that are required to be successfully in your schoolwork, but also in that social emotional learning. So my hope is that as more school systems through the State Department of Education and through additional advocacy groups are made aware of the multi-tiered systems of support, that they will be kind of relieved and given the opportunity to investigate those at-risk groups and really look at the students in a more whole perspective than strictly what do we need to be successful academically, because we know, as we discussed earlier, that what you need to be successful academically is solid mental health in conjunction with maybe additional accommodations to help you be successful. But I have gotten really some wonderful, invaluable feedback from counselors, both on personal daily challenges. I mean, even our school systems that have some robust programs in place to address mental health concerns, they have an unruly amount of outreach phone calls to provide. So when they do these surveys, there was one counselor that told me she had 95 outreach phone calls to conduct in one day to let them know that their child has been identified as high risk. So I think we all know the quality of those conversations. When you have 95 calls, you have to make in one day.
Right.
So
thank you.
Yeah, no, thank you. Great question.
Any other questions? I have one if no one else does. Allie, one of the things that Laura and Randy were so excited about was the work that's being done right now, where if a child presents at a hospital and they're identified as having these suicide ideations, what happens to that child and that family, regardless of whether they're at INTEGRIS or at another hospital? You all have a system in place now where there's a plan. Is that correct?
So we are in the process of developing a system and a plan, yes. So it is different across each hospital system in terms of what the response is, but we are working on all these different parts that I said. Remember the figure with all the little dots? Right. We're working on aligning all of those pieces and putting them together with the comprehensive crisis response system. Is that what you're referencing, Karen?
Yes, and all of the folks on this call, some way or another, touch a family or a child or multiple families and children. And they probably right now do have a plan in place for if they have a crisis and they have a child that's presenting or a family member that's presenting. But if there may be a few that don't. So at the end of the day, if they individually identify children in this situation, what should be their response? Who should they call? Mm-hmm. I have Randy Tate's home phone number. I don't ask Randy how many times I've called him. I'm not suggesting everybody does that. But short of that, what if you don't know exactly, you don't have a good resource already that you've been working with, what should people on this call do when they are presented with some of these situations with teenagers?
Yeah, absolutely. And that is top of mind. And you kind of seem to go into the deer in headlights sensation when you're actually in real time faced with that situation.
Absolutely. Yeah.
Even being a clinical professional, that happens. So I would say until we have 988, which is live November of 22, 911 is going to be the best option. And I would request a CIT officer respond to the crisis. Now, if you feel comfortable and you feel like there is not a direct threat of danger to yourself or to that individual, if you feel comfortable in asking them questions prior to making that call, I think that's completely appropriate. The important questions to ask are, do you want to hurt yourself? Do you have a plan of how you're going to do it? And do you have access to something to harm yourself? And if you can get through that conversation and kind of help them develop a safety plan of what's going to prevent you from harming yourself in the future, that is very recommended as well. But there are few situations that I would feel confident walking away from without them being evaluated by a mental health professional. So I uploaded a link in the chat. If you have not spent time exploring Healthy Minds Policy Initiative out of Tulsa, I highly recommend that you spend some time on their site. These are advocates, health policy analysts, attorneys. They produce these white papers over all topics that touch mental health. And of course, COVID-19 workforce shortages have been top of mind for their research team. So what I uploaded is a page that if you scroll down has a comprehensive list of resources for adolescents and for adults, ranging from substance use disorders to immediate crisis response needs.
This has been so helpful. Thank you so much. I am so delighted to meet you, to know that we have someone who at your early stage of your career has identified this as a major priority. And I know you're going to do wonderful things, and commend you and everyone on the health team and the task force that are working on this. And I would just share with everyone on this call, you all are the lifeline to so many different people, to so many families and children and elderly people that are in crisis. Just know how appreciated you are, but please take time for the caregiver in you and take time for yourself. I was unfortunate enough to try to be flying back from California last week and got caught in all of the angst of people, all the flight delays. And the flight attendant of 30 years told me she'd never seen the kind of anxiousness and concern and depression among passengers. Our pastor this Sunday preached on Psalms 13, which starts out talking about, gee, I'm so depressed and worried. So I think what we're going through is very normal, not just for children, but for all of us. And I just thank you all for all the work you've done and you're going to do. And I encourage you to have a great day and a wonderful week. Those of y'all that can, the Lynn Legacy Luncheon is this Thursday. There are a few seats left available. If you're interested, it's going to be talking about hope, and the wonderful Dr. Chan Hellman's going to be there. But thank you all for all you've done. Our next group, Count Me In for Kids, is totally volunteer. We're all here to work together towards helping children and families in Oklahoma be healthier and the very best that they can be. And our next meeting is November 2nd. Hopefully, prayerfully, maybe we'll be able to get together and have some real live FaceTime and hugs. Thank you all so much. If you have any questions, please email them. This is recorded and we'll make it available later. Allie, thank you so much. Everybody have a great day, and look at us, we're on time. Woohoo!
Yes, and I will say one last thing, feel free to pass along this task force sign up. If you don't have time, if you don't feel like you're appropriate and you know somebody that is, please feel free to pass along the information.
Thank you so much. And I have a feeling this is a task force that's not meeting just for the fun of meeting. but meeting to
Right.
get things done.
With a purpose, yes.
Absolutely. Thank you all so much.
so
Have a
much.
great day.
Thank you.